Welcome, everyone. We are Group 2, and we will be presenting on the topic of reducing the risk of falls in women with osteoporosis.
Osteoporosis causes a decrease in bone mineral density, so essentially older bone is broken down at a rate that exceeds new bone formation. This alters bone structure and it makes it thinned out, or it's sometimes described as porous. The main concern with osteoporosis is pathological fractures. So any bone can possibly be affected, but most fractures occur in the ribs, the ulna, hips, and the vertebra. Pathological fractures in the elderly cause an increase in morbidity and mortality and can even decrease life years. Fractures are associated with a decrease in quality of life because they limit functional capacity, they cause pain, and they affect social participation in day-to-day activities. Osteoporosis affects both genders across all ethnicities, but there are a few risk factors that increase the risk of developing osteoporosis. So there are some modifiable and unmodifiable risk factors. Of unmodifiable risk factors, being of the female gender, being of Asian or Caucasian descent, having a family history of osteoporosis, and lastly also being of advanced age or at least postmenopause for women. So advanced age is associated with decreased estrogen levels, and estrogen determines bone mineral density, so that's why that's one of the unmodifiable risk factors. For modifiable risk factors, if alcohol consumption is limited or caffeine consumption is limited, that's something that can be done to decrease the risk of developing osteoporosis. Also, smoking cessation, having regular exercise habits, and ensuring adequate intake of calcium and vitamin D in their diets. And something else to consider is some medications can be linked to development of osteoporosis if they're used long term. Some examples of these medications are heparin and steroids. Fractures occur when the bone becomes too brittle or weak. Pharmacologically, osteoporosis is treated with bisphosphonates, which slow down bone resorption or bone being broken down. Another key aspect of treatment for osteoporosis is preventing fractures. Fractures of long bones, like the femur, can cause fat or pulmonary embolism, so fractures should be taken with greater caution in osteoporotic individuals. Prevention is sought through weight-bearing activities that can improve mobility and balance. So a few examples of this would be doing yoga, playing tennis, weightlifting, taking dance classes, or just as simply as walking or doing some light jogging. Exercise is thought to reduce the risk of fractures because the risk of falling is reduced due to better balance, and exercise can also strengthen the bone by stimulating bone growth.
To further investigate the efficacy of implementing exercise to prevent falls, we developed the PICO question: do balance training exercises which increase functional mobility reduce the risk of falls in women with osteoporosis between the ages of 50 to 85 compared to women without a consistent exercise regimen? We identified the population in question as women with osteoporosis between the ages of 50 to 85. Our intervention was participation in balance training exercises which increase functional mobility compared to participation in no consistent exercise regimen. Our expected outcome was the reduction in the risk of falls. To search for studies pertinent to our PICO question, we utilized databases containing scholarly articles from PubMed and the Cumulative Index of Nursing and Allied Health Literature, also known as CINAHL. The search for relevant literature was limited to include only peer-reviewed randomized controlled trials published between the years of 2014 to 2019. Terms used in the search were osteoporosis, exercise, and women. The search generated a total of 27 RCTs with various types of exercise programs being tested on a multitude of age groups. Therefore, the target population was narrowed to include women between the ages of 50 to 85 exclusively. Upon review of the article titles and abstracts, RCTs that examine the effect of balance training exercises in relation to the decreased risk of falls were selected. Ultimately, 4 RCTs were deemed appropriate to be included in this review.
All 4 randomized controlled trials analyzed ultimately supported the use of balance training exercises to reduce the risk of falls in osteoporotic women. As Geneva et al., Miko et al., Olson and Berglund, Otero et al. Of the 4 randomized controlled trials analyzed, the article by Otero was found to provide the highest level of evidence supporting the use of balance training and the prevention of falls in osteoporotic women. This is due to the study being a randomized controlled trial, which provides the highest level of evidence and the ability to limit various sorts of bias, having a longer program duration lasting from 6 months to a year, which allowed researchers to gather ample data, and having a high attendance rate, which also allowed researchers to gather the needed data from a larger sample size. The Geneva study explored how effective physical exercise programs could reduce pain, fractures, and improve quality of life and balance in women with osteoporotic vertebral fractures. These reductions are due to weight bearing and squat tests, which ended with a p-value of 0.968, tandem walk and sway, which ended with the p-value of 0.317, and weight transfer, which ended with a p-value of 0.928, and left-right weight symmetry, which ended with a p-value of 0.554. Miko's study showed that incorporating sensory motor, traditional and aerobic exercises can be useful in improving postural balance, reduction of falls, which had a p-value of 0.17, and aerobic capacity, which had a p-value of 0.17. Olson and Berglund's article, researchers proved that the use of balance training coupled with patient education resulted in the reduction of the fear of falling, which had a p-value of less than 0.001, and increased mobility with a p-value of 0.02. This can be attributed to the baseline fall efficacy scale international score decreasing from 24.9 to negative 2.7 by the end of the study. In the last article by Otero, researchers demonstrated that low-intensity balance and strength programs produce significant improvements in upper and lower body muscular strength, static and dynamic balance. These findings are in conjunction with the test used in the study: static balance with a p-value of less than 0.001, dynamic balance with the p-values less than 0.001, and upper limb muscular strength with a p-value of less than 0.001, and lower limb muscular strength with a p-value of lower than 0.001. All 4 articles analyzed supported the use of balance training in the prevention of falls in osteoporotic women. However, each study has their own limitations that can alter and skew results. In the article by F.S. Geneva, participants in the exercise group did not use the therapy gym during the study, and those who performed the exercises at home may have done them incorrectly. A blinded assessment was done, but only for the stabilometry and quality of life questionnaire, meaning alterations of findings could have occurred in other aspects of the study. Lastly, the optimal period of exercise was not specified, which would have been beneficial if participants exceeded the 12 months. The article by Miko had a small sample size, thus allowing results to affect the reliability and having a higher variability, which in turn would lead to bias. Also, complete blinding was not possible as the leading physiotherapists were aware of who was in the treatment group. This is negative because blinding is important in reducing or eliminating experimental bias. In the Olson and Berglund article, the sample size was also a limitation, as it caused researchers to consider this a weakness and inform readers that generalizability of results should be made with caution. Participants were also self-selected into the intervention group and control group. This self-selection caused participants to become disappointed in their position within the study. Lastly, in the Otaro article, the sample size was again a factor of limitation. Another limitation was a new development in the use of vitamin D and its positive outcomes in balance and prevention of falls.
Before we talk about our recommendations for future research, we wanted to go over strengths, weaknesses, and limitations we came across as we dove deeper into the articles we selected. As with any study, there are pros and cons. So let's start with pros. For strengths, we found that choosing randomized controlled trials was a strong factor in terms of having more reliability and there being less room for bias. We also found our studies had a high adherence rate, with one study being as high as 89.2%. We found that 3 out of the 4 studies we used included an exercise program lasting at least 6 months, with 2 of them going up to 1 full year. We believe this played a key role in proving exercise can reduce fractures in osteoporotic women. So now that we've talked about our strengths, let's go ahead and talk about some weaknesses. One of those weaknesses being sample size. Earlier we mentioned some programs lasted up to 12 months. Well, with a small sample size, you run the risk of participants not completing the program, which happened in nearly all of the studies we used. We also noticed in one study, participants not selected to perform the exercises in a gym under supervision were allowed to perform the exercises at home. There was no way of telling if these participants did the exercises correctly and for the correct amount of time. Also, if a fall were to happen at home, there is the issue of it not being reported, so that's another area to consider. Lastly, one study had exclusion criteria. Participants with certain comorbidities could not participate. It would have been really interesting to see if the effects of an exercise regimen for individuals with cardiac or pulmonary issues. There are many women out there with osteoporosis who have comorbidities, so there is a missed opportunity there to see if exercise would not only help with reducing fractures, but also help with other health issues simultaneously. Although the studies we used supported our PICO question, there are areas to consider for future research. One of the areas would be including a quality of life questionnaire before, during, and after the exercise program, just to showcase the positive effects of fall prevention in osteoporotic women. It's also important to consider whether or not participants in the program were actively taking medications or supplements prior to or during the program. Other areas we recommend consideration would be choosing studies that involve exercise programs with the same length of duration, with the same sample size, and are under the same type of supervision. As a group, we felt alignment in these areas would have strengthened our PICO question a bit more, so we recommend considering these areas for future research.
This concludes our presentation. Thank you so much for listening.